Hi students. So these classes basically will be discussing about the medical nutrition therapy for diabetes. Basically we'll be talking about hyperglycemia and also hypoglycemia, and not only the medical nutrition therapy but also we'll be discussing about the pathophysiology, hypoglycemia management and lifestyle management. So let's the ball rolling. So what diabetes? So diabetes mellitus is a group of metabolic diseases characterized by high blood glucose level, disturbances of carbohydrate, fat and protein metabolism resulting from defects in insulin secretion or action or both. Diabetes mellitus, commonly referred to as diabetes, was first identified as a disease in the ancient world and associated with the sweet urine and excessive muscle loss. Elevated levels of blood glucose, which is called hyperglycemia, leads to spillage of glucose into the urine, hence the term sweet urine. Hyperglycemia or high blood glucose levels occur when there is not sufficient insulin to achieve normoglycemia. Either the body has stopped making insulin, which is type 1 diabetes. I'll be discussing about the classification of diabetes later on in this session, or there is insulin, but the amount of insulin is less than what is required or it is working inefficiently. That is type 2 diabetes. Exposure to hyperglycemia over time may damage tissues in organs throughout the body, according to ICMR 2005. So, if we talk about diabetes, then we should talk about the classifications of diabetes because there are several kind of diabetes. So again, I'm just repeating from the slide. Diabetes mellitus is a clinical syndrome characterized by hyperglycemia due to absolute or relative deficiency of insulin. Diabetes is not a disease. Is basically, you mean to say, is a metabolic disorder or metabolic disease, you might have said, but it's not a disease, but is a metabolic disorder and characterized by persistently high blood glucose due to defects in insulin production or in insulin action. So in the both way, either it's insulin production or is the insulin action. Maybe they have sufficient insulin but not acting properly. So they are several classified of diabetes mellitus. What happened in diabetes? Just see the picture. There are the two, abbreviations of the picture. There are two separate pictures. One is a normal person, another is the person with diabetes. In normal person, number one, starch in food is converted to glucose. Number two, glucose entered to the blood vessel. Number three, the pancreas makes insulin. Number four, insulin enters the blood. Number five, glucose enters the cell. So insulin is something, is a very crucial and important hormone which is functionally active for, the transportation is a very important in the presence of insulin. But if we see the picture in a person with diabetes, this is starch in food is converted to glucose. Number one, the same process glucose enters the blood. This is number two. Number three, the pancreas makes insulin because pancreas is making insulin, the normal process. Number four, insulin enters the blood but cells do not recognize insulin. So this part would be the differentiate between number 4 from the normal person, then number 4 from the diabetes person. So insulin enters the blood but cells do not recognize, cells can't recognize insulin. And number 5, glucose can't get into the cells of the body, glucose builds up into the blood. That's why high blood glucose into the blood is called the hyperglycemia. Normal high blood sugar is called, it's called that starvation amidst plenty. Have the thing, have the food, have the glucose, but body can't utilize due to insulin either action problem, either production problem. So this is the way you can understand what is the difference physiology of a normal person and different physiology from a diabetes person. Now we're coming to the pathophysiology. So if we talk about the normal physiology, then what will happen? There is a food. From the food, it will come to the intestine. Intestine is the blood glucose. Blood glucose will go to the liver, stored as glycogen. We know the excess sugar is stored as a glycogen in our liver and muscle. Liver and muscle is called the glycogen. Blood glucose goes to our kidney. Our brain, stored as a fat, is the adipose tissues. And from the kidney, urine production, that is plasma glucose, is like 180 mg by dl. This is the normal physiology. This is the normal physiology. But what would be the pathophysiology of the diabetes mellitus? So, insufficient insulin. Insufficient insulin will come to reduce tissues uptake of glucose. The both way, intracellular hypoglycemia, extracellular hypoglycemia. From there, glucogenesis and gluconeogenesis happens, and from there, breakdowns of fats, high levels of ketones, diabetic ketoacidosis. And the same way, decreased protein synthesis, cachexia, lethargy, polyphagia. Decreased gamma globulin, susceptibility to infection, impaired wound healing. In case of the extracellular, hyperosmotic plasma, dehydration of cells, hyperglycemia, coma. Blood glucose, renal threshold, glucosuria, urine has a high Hg, osmotic diuresis, polyuria, polydipsia, hypokalemia, hyponatremia. You know, hypokalemia means their potassium level is lower potassium level from the optimum level from the blood, and hyponatremia means the lower sodium level. So this is, and you know the biochemistry of glucogenesis, gluconeogenesis, and also glycolysis. Okay, so that is very important. Glucogenolysis, glycolysis, these all are very important. So in that cases, this pathophysiology is very important, that you have to understand the difference between normal physiology and the pathophysiology. So what is the fasting plasma glucose test? You call the FPG test. So it test basically denotes the blood sugar levels in the body due to the glucose production by the liver. Prefers test for the screening blood sugar. So in diabetes, basically is the 126 mg by dl is a greater than 126 mg by dl is called basically the pre-diabetes stage. Okay, is called the pre-diabetes stage. Sorry, 126 by mg by dl till 126 mg by dl is called the pre-diabetes. I'm just coming from the normal side, that will be clear to you. In normal is 100 mg by dl till 100 mg by dl is called the normal. You can see the green signal is there, is the normal. What is pre-diabetes? 100 mg by dl to 126 mg by dl. This is the yellow sign, is called the pre-diabetes. But if diabetes more than 126 or greater than 126 equal or greater than 126 is called diabetes. Is called diabetes. So in lab report, you can get the varial report because in lab report they are following the fasting blood sugar, postprandial blood sugar, and the random blood sugar. In case of fasting blood sugar, the range is 70 to 1110 mg by dl. In case of postprandial is 80 to 140 mg by dl. But in cases we can see the fasting plasma glucose if more than 126 by mg by dl equal and greater than is called the diabetes. So at least 8 hours fasting that has to do. The standard diagnosis of diabetes is made when two separate blood FPG diabetes tests show that your fasting blood glucose level is greater than or equal to 126 mg by dl. So that is very important. So you have to understand that they are equal and greater than 126 mg by dl means the patient is diabetic patient. This is the diagnostic test basically we are talking about. GDM, gestational diabetes mellitus. In case of pregnancy, when a pregnant woman develops diabetes, it is known the gestational diabetes mellitus or GDM. It occurs is only 1% of the pregnant women. Pregnant women who have a risk of diabetes because of family history or the bad obstetric history should be screened for diabetes. Pregnant mothers develop diabetes related complication and after delivery can also continue with the diabetic condition. Beside the type of diabetes discussed above, there is another diabetes is called the MODY, that is maturity onset diabetes in young, and also LADA, latent autoimmune diabetes. But apart from three of these, there are also other diabetes is called the malnutrition related diabetes mellitus. You can follow your book, you can get in details what is malnourished people, how come diabetes can occur, and also impaired glucose tolerance, the IGT. That is also important, that in the high time that you have to come you have to make make sure that you're adhering a proper clinical nutrition and dietetics management for controlling the diabetes, because borderline diabetes is very crucial. You shouldn't allow to go for the beyond the threshold. That is very important. So in the type 2 diabetes mellitus we are discussing about is 90 to 95% of the all diagnosed cases. What are the risk factors? Older age, obesity, family history of diabetes, definitely with pedigree, prior history of GDM, gestational diabetes, impaired glucose tolerance, physical inactivity, and the race and the ethnicity. So in GDM, gestational diabetes mellitus is a glucose intolerance or diabetes diagnosed for the first time during pregnancy. Develops in 7% of the all pregnancies, disappears when pregnancy is over, occurrence with family history of diabetes, occurrence with obesity. What would be the possible effects of the GDM? You can see maternal hypoglycemia, fetal hyperglycemia, fetal hyperinsulinemia, fetal macrosemia. Macrosemia means large baby is called the macrosemia. So these will be the possible effects of the GDM. What is macrosemia? Mother's blood brings extra glucose to fetus. Fetus makes more insulin to handle the extra glucose. Extra glucose gets stored as fat and fetus become larger than normal. Fetal macrosemia can be seen in up 40% pregnancies. Microsemia can lead to high incidence of the fetal trauma, incidence of the stillbirth and the neonatal complications. So that is very important. Now, now we are coming about the complications of the diabetes. What would be the complications of the diabetes? So, if we talk about diabetes related comorbidities, diabetes related comorbidities, from there we can get to know what would be the complications of the diabetes. You can just find the slide where you can see the complication. So there are the complications could be two types. One is the macrovascular disease or macrovascular complications, and another is the microvascular complication. So in case the macrovascular complication or macrovascular disease, there definitely coronary heart disease is one of that. So heart disease, coronary heart disease, stroke, kidney disease, brain disease, all under macrovascular complication. So I in last lecture I have discussed about what is the coronary heart disease. So I have that time I talked about that comorbidity. Yes, from the diabetes the comorbidity has started. That's the heart disease, high blood pressure, kidney disease, and also stroke, the brain disease, CNS, central nervous systems affected, is the macrovascular complications basically. And also there are the eye problem will be there, which is called the microvascular complication, that is diabetic retinopathy. Diabetic retinopathy or eye disease is a very crucial for that. Also there are diabetic nephropathy, diabetic peripheral vascular disease, okay, nerve damage, peripheral neuropathy, impaired blood flow to the lower legs, all are basically the diabetic neuropathy. So this is very important in the cases if we talk about the macrovascular complication, neuropathy, diabetic nephropathy, diabetic peripheral disease, and retinopathy. So that is very important. All are the diabetes related complication. But complications will not one go. It is over time, high levels of blood sugar, uncontrolled, indiscipline, very distractive lifestyle. So that will lead to this kind of complications most certainly. So what would be the treatment of diabetes? If we talk about the treatment of diabetes, definitely medical nutrition therapy is the major part, because you are all being a MSc nutrition dietetics student. You should know that the diet is the major part of these things. Also medications are there, oral hypoglycemic drug, insulin therapy is there, and also exercises. So diet, medication, insulin therapy, exercises, overall a balanced diabetes management approach with lifestyle modification can help a person control their diabetes. You have to know that once you are diabetic, entire life you will be diabetic. But the major thing is that you can control your blood sugar level with the optimum range. why diet is important. So diabetic is a metabolic disorder. So diabetes is a metabolic disorder affecting the metabolisms of the food. The food is the carbohydrate, protein, fat, is all the food. So that is very important that you have to maintain a proper diabetes through the diet. So diet plays a very important role on the onset of diabetes, and also the the optimum nutrition, balanced nutrition, maintain blood sugar to the glycemic control, achieve optimum blood lipid levels. That is very important. Not only that, but also body weight, BMI, age, sex, activity, social cultural factors, economic factors, the type of diabetes, is the renal disease, yes or no. So all these things, because being a dietetic student, you must have known there are a lot of stages of a activity level. Some people are sedentary, some people are moderate, some people are heavy worker person. So accordingly, we have to take care of that. So in the food, we know basically the glucose, fatty acid, amino acids, the monomeric form also, high blood glucose levels, high blood lipid levels, low immunity, loss of muscle. We have to take care all of this. So if we talk about the calorie requirements of a diabetes patient according to weight and activity, is a ideal body weight, sedentary activity, calorie requirement 25 kg per ideal body weight. Ideal body weight, moderate activity 30 per kg ideal body weight. Overweight, sedentary activity 15 to 20 per kg ideal body weight. Underweight, sedentary activity 30 per kg ideal body weight. Moderate activity, underweight 35 per kg ideal body weight. So this is the normal standardizations for the theoretical part, but definitely practical there would be differences according to person to person. It's not a kind of a fix, because once you people are going to make a diet chart during your internship days also, I'm very first guiding you students that there is a no printed or fixed diet chart for everybody. There would be customized dietary plans, customized nutrition, dietary counseling plans, and also management for person to person. Maybe in dietetics practical days it will be help you to understand the arithmetic calculation, NIN calculation, and also the exchange size calculation. But you have to apply during the patient visit. Okay, so this is not a fixed kind of a chart kind of thing that. So role of diet, definitely what I've discussed, weight loss and maintenance. Weight loss means that is not the weight loss, maintain the proper BMI. That mean to say in the slide. Blood glucose control. You can see this is the control machine used to call the SMBG. Self monitoring blood glucose machine. SMBG is very important that you have to person, a diabetic person can keep a SMBG machine for regularly maintaining the diet, their blood glucose levels, and also document it into the logbook. Improved overall health activity, blood pressure control, blood lipid control. There shouldn't be any atherosclerotic plaque. That shouldn't be, because your cholesterol, your triglyceride, everything should be on normal side. Because if it is not, then your diabetes can't control. index 72, my god, is a high glycemic index. 72 means is under the high glycemic index section. But if calculate the glycemic load, means 72 divided by 100 into 6, because 6 gram of carbohydrates is under 4.32. So 10 and less. So yes, watermelon can have. So this is the way, students, I want that you will calculate the glycemic load and the glycemic index before suggesting. Now we will talk about the dietary fiber. Also, I have covered this dietary fiber part in the cardiovascular dietetics MNT also. But again, the same thing, because there is a constant thing. The same thing will applicable in diabetes also. The RDA is the 40 gram per day recommended dietary allowances, 40 gram per day, in combination of soluble dietary fiber and the insoluble dietary fiber. Insoluble dietary fiber can be found in food such as oat bran, barley, nuts, seeds, beans, lentils, fruits, all are the soluble dietary fiber. In insoluble fiber is found in the foods such as the whole wheat, whole grain products, vegetables, and the wheat germ. So that is the insoluble dietary fiber. That is very important, the soluble dietary fiber and the insoluble dietary fiber, that has to reflect in your diet chart, that what is soluble dietary fibers and what are the insoluble dietary fibers. Now we will talk about soluble fiber. So, soluble fiber, what will happen? Increase viscosity when dissolved in water. High viscosity influence nutrients absorption by delaying gastric emptying, reducing transit time in the small intestine. Gum acacia, guar gum, soy fiber, pectin, inulin, peas, all are under the examples of the soluble dietary fiber. Clinical trials shown that soluble dietary fiber like guar gram, oat bran, pectin can be useful in decreasing insulin requirements, improving glycemic control, lowering serum cholesterol level. Soluble and insoluble fibers reported to the delay glucose absorption. Dietary fiber can promote satiety and assist also weight. I will try to just highlight about a few things, that is the fat part, that is very important, the fat part also. That fat is the very essential, like you know, oils and fats is very essential for maintaining the diet. Okay, so what kind of fat? Also I have discussed about the fat part on the cardiology, that the same thing is applicable. Total fat recommended by WHO is less than 30% of the total calories. However, in view of the widely prevalent Asian paradox in India, in general recommend not to provide more than 15 to 20% fat of the total energy from the dietary fat. In that cases, polyunsaturated fatty acids is 10%, saturated fatty acid 7%, monounsaturated fatty acid 10 to 13%. The dietary cholesterol intake should be kept below 300. I'm saying 250 to 300 mg per day for diabetes without any complications, because we know there are the food sources like all the animal sources, they contain lot of cholesterol. Okay, because cholesterol only found in the animal part, plant part doesn't have too much of cholesterol, they have the plant sterols, but cholesterol only found in the animal sources. We in that cases, in cholesterol, like food like whole milk, egg yolk, red meat, organ meat, ghee, butter, cheese, cream, all are under the cholesterol triglycerides. So we try to avoid of this part. And also, choices of oils are very important. Choices of oils are very important. You know why I am saying? Because there are the classifications of oil. If we take saturated fatty acid, MUFA, PUFA. We know PUFA. There are the two classifications also, omega 6 and omega 3. So these are there. Like there, olive oil is there, peanut oil is there, canola oil is there, rapeseed oil is there, sesame oil is there, corn oil is there, soybean oil is there, sunflower oil is there, safflower oil is there, coconut oil is there, hydrogenated oil is there, ghee and butter oil is there. Ghee and butter is not a oil because they are saturated fat, means the uh, uh, solid in room temperature, that you know very well. Okay, there is no any double bond, only single bond is there. So if you need these cases, these charts, I will definitely send you to the department. You will get from the department. Okay. So now we are going forward to the protein part, because protein is a very integral part of managing diabetes. Okay. The role of So there is a 20 different types of amino acids. We know essential amino acids, 20 different types of amino acid, basic building blocks, that is 11 non-essential amino acid and the 9 are essential amino acid. Amino acids, amino acids are linked together in a chain like letters forming in a word. Protein chains are very much longer than words. Average English word contains 4.6 letters. Average protein contains 1000 amino acids. Because we all know what are essential amino acids and what are non-essential amino acids. It is very important, students, that you have to remember the essential and non-essential amino acid. Because we know, if we try to sum up, there are the methionine, tryptophan, valine, isoleucine, leucine, phenylalanine, lysine, threonine, arginine, and also histidine in case of infants are the essential amino acid. Out of these, valine, isoleucine, leucine are called the what? Called the branch chain amino acid, BCAA. Because you must have known what is the branch chain amino acid. That is very important role for managing infective hepatitis, or the patients are jaundice or these icterus patients. Okay. And what are the non-essential amino acids? That are glutamic acid, align, proline, hydroxyproline, glycine. All are the non-essential amino acids. Examples of non-essential amino acids. So these are very important, that you have to understand what are the essential amino acids, what are the non-essential amino acids. Essential amino acid our body can't produce. That's why we depend on the outer dietary sources to replace it. So they are the 50% essential indispensable amino acid. Body is unable to synthesize them for building protein, that is growth, obtained totally from diet, what I have discussed. And in case of non-essential amino acid, body can synthesize adequate amounts from the other molecules in the body, need not be present in the diet. If it is present, it's okay, but it's not present, it's all right, because we always try to search essential amino acid from our dietary sources. Okay, that is very important. These functions you know very well: that protection, hair, skins and nail, immune systems, antibodies, hormones, insulin, ACTH, adrenocorticotropic hormone, FSH, follicle stimulating hormone, respiration, hemoglobin, water balance, albumin, eyesight, rhodopsin, metabolism, enzyme. These are all are the examples that protein can if we discuss about the nitrogen balance, if we discuss about the nitrogen balance in the protein, that is very important, because you know only the protein hexagon cycle there nitrogen is present. Okay, neither carbohydrates nor fats, only protein contains nitrogen. Okay, so how do you balance the nitrogen balance? Increase in the body protein growth, blood transfusion, dietary intake, bacterial synthesis of amino acid, loss of body protein is a weight loss, urinary nitrogen, facial nitrogen, and integumental losses. Okay, so that is very important that you have to calculate. Okay, so how do you calculate? How do you calculate the nitrogen digestibility coefficient? That is 100 into n intake, 100 into nitrogen intake minus n in phases, endogenous phases, divided by n intake. So this is the way you have to calculate the nitrogen balance. So nitrogen balance is very important. Nitrogen intake minus subtract nitrogen excretion. This is the way you have to maintain the nitrogen balance. So protein in RDA says this 1 gram per kg per day mixed protein recommendation, 15 to 20% of the total calories in a day. Requirements of proteins may be high in uncontrolled diabetes, because mixed protein means is a good biological value protein is there should be there. How do you calculate the biological value? Biological value equals nitrogen digested minus nitrogen loss in metabolism into 100 divided by nitrogen digested. So nitrogen digested minus nitrogen lost in metabolism into 100 divided by nitrogen digested. You all have studied in biochemistry, so again you have to sum up. Type 2 diabetes with moderate hyperglycemia plus restricted energy diet, increased protein turnover, negative nitrogen balance, increased need for protein to maintain lean body. Protein intake and diabetes control is very important slide. So it is a very reference of the Clinical Nutrition 2002. Diets with increased protein and reduced carbohydrates have been shown to improve glycemic regulation in normal subjects and people with type 2 diabetes mellitus or obesity. These included reduced plasma protein glucose response, modifications of the insulin response, and reduced HbA1c. Studies in diabetes suggest that diets with protein contain 20% of the total energy reduce glucose and insulin concentration, reduce appetite, and increase satiety. Substituting dietary protein for carbohydrates reduce meal responses for the both plasma glucose and insulin. That is very important. So, if we discuss about the protein intake and the weight loss, that is very important that low carbohydrate, high protein diets have been popular for the weight loss. Study shows that the high protein is 1.05 gram per kg diets favorably affect body composition independent of the energy intake. Protein intake has been shown to be a significant predictor of the fat-free mass retention. Moderately increasing protein and reducing carbohydrate also have positive effect on weight loss. Increased protein and reduced carbohydrates diet were found to be effective in FM loss, improving body composition and the lipid profile during initial as well as the long-term maintenance. That is very important. So now we're talking about what are the hydrolyzed protein. Protein hydrolyzed a mixture of peptides mainly containing dipeptide and the tripeptide. The proteins are hydrolyzed by splitting a protein with acid, alkali or enzyme. They are also referred to as the pre-digested protein. Hydrolyzed protein provide the nutritive equivalent of the original material in the form of its constituent amino acids. That is very important. So these are the picture of a hydrolyzed protein versus intact protein. The roles of the vitamins and minerals in diabetes. That is very important. The roles of vitamins and minerals in diabetes because we know there the lower level of magnesium are associated with the risk of diabetes. Magnesium depletion has been associated with insulin insensitivity, which may improve with oral supplements. Chromium supplementation has been shown to exhibit beneficial effects in the diabetic patients. Mineral and other vitamin supplementation must be considered during infections and complications or situations such as extreme weight reducing diet, strict vegetarians, pregnant, lactating, and elderly, or those individuals who are on drugs and have malabsorption disorders and the other elements. Sodium restriction is suggested for the hypertensive diabetics or those who are suffering from renal complications or edema. In our discussion, basically we talk about the vitamins which and minerals which are important in our diet for combat diabetes. So selenium is one of a good nutrients that can help to combat diabetes. Now we are talking about hypoglycemia, quote unquote hypoglycemia or alert hypoglycemia is a very important chapter because we know if a diabetic patient is not regular of their meal time, basically skip their meal, exercises without having any meal, they can fall to hypoglycemia. So hypoglycemia is a very important chapter that we have to be understand very carefully. So in the diabetes treatment in Bricos and Davies in 2006, this leads a very common uncomfortable feeling and the risk of the losing consciousness. This can be frightening and may also be a cause for embarrassment or the social work. In the past, glycemic goals allowed for the higher levels of blood glucose in order to minimize the risk of the hypoglycemia. So basically, why it's happened? Too much medication causing higher than needed insulin levels, number one. Number two, the prolonged action of certain medication. Number three, not eating enough food to match the insulin level in the bloodstream. Number four, not eating at the proper time, skipping or delaying meals. Unplanned, number five, unplanned or excessive exercise leading to a lower blood glucose level. So these are the mainly the reasons for being a person hypoglycemia. So when can we say a person is hypoglycemic? The level of glucose when symptom of the hypoglycemia appear varies from person to person. Hypoglycemia is a risk of all insulin treated people with diabetes in people taking oral medication for the diabetes classified as insulin secretages. These oral agents stimulate insulin secretion by pancreatic beta cells. The hypoglycemia reaction may range from a very mild lowering of glucose 60 to 70 mg per dl with minimal or no symptoms to severe hypoglycemia with very low levels of glucose, that is less than 40 mg per dl and neurological impairment. Symptoms of hypoglycemia may also occur when the blood glucose level falls rapidly from a high level to a lower, but the patient is still at an elevated blood glucose level. This is related to the hormonal response to what the body perceives as a low blood glucose level. The response is related to the rate of the fall of the blood glucose as opposed to the actual blood glucose level. So in case of hypoglycemia, there's a very important role of the glucagon and the epinephrine. Okay, so glucagon and epinephrine are the primary fast acting hormones are the defense against the acute hypoglycemia. So if we discussed and categorizations of hypoglycemia, if we do it, then there are the mild hypoglycemia, moderate hypoglycemia, and also and also the severe hypoglycemia. So in case of mild hypoglycemia, adrenogenic response, in the early stages of hypoglycemia, people may feel all some or in some cases none of these signs and symptoms like sudden hunger, headache, shaking, fast or pounding heartbeat, sweating, tired, dizzy, blood vision, nervous, excited, drowsy, numbness or tingling around mouth or lips. Moderate hypoglycemia, that is the neuroglycopenic response. If the reaction is not treated, the brain begins to lack glucose and the symptoms may progress to, that is, personality change, irritability, confusion, poor coordination, difficulty concentrating, slurred or slow pitch. In case of severe hypoglycemia, neuroglycopenic response, non-capable self-treatment. If the reaction is not treated and the blood glucose continues to fall, the person may go into a coma or develop seizures. So in that cases, so hypoglycemia, while people who do not have any metabolic problems can complain of symptoms suggestive of low blood pressure, true hypoglycemia usually occurs people being treated for diabetes type 1 and type 2. Individuals with prediabetes who have insulin resistance can also have low blood sugars on occasion if their high circulating insulin levels are further challenged by a prolonged period of fasting. There are other rare causes of hypoglycemia such as insulin producing tumors, insulominas, and certain medications. So this is all about a general idea about MNT of diabetes mellitus. In next session or in the next lecture, we'll be discussing about the pharmacology and insulin management of diabetes. Thank you.